and a patient that by the psychiatrist had been increased to 3 times the normal amount of medication, okay? When I got back their profile, it said that they were a metabolizer of the drug such that they needed 1/4 of the lowest dose. Okay.
So they had 32 times.
They had 32 times the amount that they needed. They had not normalized on their depression rating scale. And I immediately took that patient, and contrary to all guidelines, I took them from the highest dose down to a 1/4 dose. The next time I saw that patient, they had normalized on their depression rating scale. Totally normal.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their D-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. In this episode, we explore pharmacogenomics, also known as genetic pharmaceutical profiling, with Dr. Lyndell Scoles with MDVIP. He's an early pioneer in using genetic testing to optimize medication choices. With over 30 years of experience in internal medicine, Dr. Scoles shares how genetic pharmaceutical profiling helps determine which medications will work best for each patient based on their unique genetic makeup. He presents compelling examples of how this approach has prevented hospitalizations and improved patient outcomes, including cases of heart failure prevention and depression treatment. We also discuss why this hasn't been widely adopted yet in medical practice, despite its potential to save billions in healthcare costs. Note: as for our first in-person recording, you may notice some echo and compressed audio quality in portions of the conversation. We appreciate your understanding as we continue to improve our in-person recording setup.
Hey everyone, welcome to the Precision Medicine Made Simple podcast. Today we are excited to explore how personalized care incorporating pharmacogenomics can revolutionize patient treatment by tailoring medication to an individual's genetic makeup. Our guest has over 30 years of experience in internal medicine, holds numerous accolades, and has pioneered genetic pharmaceutical profiling for over 600 patients. Please give a warm welcome to Dr. Lyndell Scoles.
Thank you.
Thanks for coming by. And this is a pretty special episode as well, considering this is our first in-person episode, and we're recording here from Columbia,
Missouri.
Columbia, Missouri, not Columbia, South Carolina, which is also where you were from. Well, it's not from, but you did your undergrad.
Yeah, I did my undergrad. It is certainly coming home for me.
Yeah. And so before I guess we dive into the conversation, I feel like, especially with people within our network, I always am curious as to how we got connected in the first place. And so Dr. Scoles, did you know Dr. Stanford beforehand?
No, I was introduced by Dr. Bill Turpin, and he knew Dr. Stanford, and they linked us up together. And I think that the way that I came to know him was that he came to me as a patient.
All right.
Gotcha. And from my understanding, and then correct me if I'm wrong, not many doctors have used pharmacogenomics in their practice. I'm curious about what piqued your curiosity to start using pharmacogenomics in your practice?
Okay. Back when I switched over to MDVIP, which is kind of a concierge program, I was looking for various things that I could incorporate into my practice that were on the cutting edge, and I began to read about it. And we had several uh, Alpha Genomics out of Kansas City, I believe, was the first that contacted me and said, uh, would you consider this in your practice? And so I read about it and decided that specifically genetic pharmaceutical profiling would fit in my practice. And I felt like that was something that could lessen side effects of medications. And I had done a study early in my career that in the call group that I was in, 25% of the admissions to the hospital were related in some way to someone getting the wrong medication or some doctor prescribing not knowing about another doctor's prescription and the interactions. And so I felt like in order to cut down unnecessary hospitalizations, 25% sounded like a good goal to reduce hospitalizations. And so I said, I'm going to do this. At that time, the genetic company that I was working with said, if you cannot get the insurance to pay for this, we will eat the bill. And they allowed me to do basically 650 different tests on people at no cost to them. And so that launched me into saying that I probably should be doing this on every patient. And so that's how I got into it. The government later came along and said, hey, you can't do this. And I responded, well, it's saving you a lot of money because I'm keeping people out of the hospital and there's less trial and error that goes into my choices as far as medications. And we're having better outcomes, and I can prove that financially to you. And they still said, it's not legal.
What did they like about it?
They said that it was falsely incentivizing me to order the test that wasn't covered at that time by Medicare. And
The old technicality.
the interesting thing was they approached me about a year later and said, would you be a regional director for a study that we're doing on pharmacogenetic profiling? And I said, how many genes are you going to test? And they said 8. I said, well, I'm doing 23 right now, so I'm not interested in taking a step back in what I can learn. And so I declined that directorship that they were offering me to do that. So,
And in out of curiosity, then when somebody was to, let's say, get their pharmacogenomics done and they've gone through genetic testing, was it through a blood draw? Was it through a spit test? Like, how did they actually collect the sample?
well, the test is done through a cheek swab, and you take it and rub it inside of the cheek, making sure that they haven't had anything to eat or drink recently, and get a good sample of cells from the cheek. And typically what I've seen is that there are 2 different swabs, and so we do both sides, and then we package those and send them in to the genetic company, and they extract the DNA from that to run the testing. And so there's once that is done, then you get back a real extensive report, and it basically divides patients into 3 different categories. This medication is effective and will work in this particular patient, or this particular medication will need to be modified as far as dosing in order to be effective in a patient. And then the third category is this medication's not going to work in this patient because of their genomics. And so it gives you clearly on a large battery of medications in basically all fields of medicine what will work and what will not. And it's just very interesting whenever you start to do this testing on patients, the results that you get, and it explains a lot about why you've had success and failure in other cases. And so you immediately begin to think of those variations and try to, even if you're not allowed to do the testing, you will pick up on things a lot of times that you wouldn't pick up on because the medication isn't working in a patient. You'll rethink things real quickly.
Did any patients opt out? You know, how many of the people you offered this free test said,
I don't recall anyone opting out. You know, I'm sure that there are people out there that don't want their genetic material extracted and out in what they would call a public record, even though it's protected by HIPAA and all. But I didn't have anyone that I recall that said that they didn't want to have it done. Especially, you know, when at the time, I believe that the actual cost of the test was $3,700 or something like that. And so you were getting a test that was pretty expensive for, you know, basically no cost to the patient. You know, the genetic company, to their credit, they ate the bill on a lot of patients because it wasn't covered by their insurance, or if their insurance would cover a certain amount, they just wrote off the remainder of the bill. And so it was a real service to the community. And
what year was this again? Or what time frame?
probably at least 10 years ago. Yeah.
So you were really an early adopter.
Yeah. I felt like that, you know, and there's multiple things that I incorporated in my practice at that time. It wasn't just genetics, but, you know, some of the early devices as far as what you could do. I was doing telemedicine at the time for Boone. I was the director of the telemedicine unit. And so I even had a patient in Zaporozhye that was having a heart attack, and I had
Zaporozhye.
Yeah,
What's that?
that's clear over in Ukraine.
Oh, so that's a
Yeah,
region.
it's
of
a region
Ukraine.
of Ukraine. It's so I had provided him with an EKG machine where he could run an EKG because he had a heart condition, and then I had a stethoscope that I could listen to his heart over and lungs over the phone line and things like that. And so we had video conferencing where we could video him, and I could tell he was having a heart attack by the EKG that we had him run. And we coordinated a flight to Turkey for him to have a heart cath, and he's still living today because of that.
Wow.
That's,
Sorry.
you know, it's just things that
Again, what year would that have been?
probably, I would have to look back at the record, maybe at least 10 years ago.
Yeah. So, I mean, it sounds like at least 5 or 6 years before COVID and telehealth hit the scene. Yeah. Amazing.
Yeah. But, you know, other devices that have come along since then are just incredible. Even the Apple Watch to run a heart tracing and you know, immediately tell if somebody needs to get to the emergency room, and they can send me that in 2 minutes, and I can make that. But
To detect atrial fibrillation.
well, and it's not only that, but you know, since they can send it to me in a PDF file, I can look at that and see if they're in VTAC or some other fatal arrhythmia too.
Sure.
It's not just looking for AFib. It's and it's as accurate, I believe, as an EKG.
Sure.
And
And those are live cores. You've seen those.
We've had those. We started with the 6-lead, actually the 2-lead alive core, and used that. And then when they came out with the 6-lead that you can put on your knee as well, we could get a 6-lead EKG tracing, and you're missing 6 leads, but you can tell a lot from a 6-lead EKG coming over on a PDF file that you can print out and look at, and analyze.
Let's have a 12-lead one now.
I haven't seen that one yet.
I just saw that in the last week. That's cool. I don't know how they're doing the precordial leads, but that would be really interesting.
I'm so sorry. Where leads?
EKG.
When you go, you get the EKG, there's a left arm lead, a right arm lead, and they usually put one on the leg, and then usually the left, right, and then they have 6 across your chest like this. So basically, they're looking at, the way current flows, the way that electrical pulse from the heart propagates out to these leads, and by looking at that characteristic squiggly line, you can discern a lot of pathologies, like he said, with rhythms, but you can also, on a 6-lead or 12-lead, start seeing things like segment depressions or segment elevations, which can tell us the patient may or may not be having a heart attack. But not that that's the gold standard, but if they're in East whatever Ukraine, it's any port in a storm at that point. And these devices are not prohibitively expensive. So like this device that will do the 6 leads, like $129. I mean, you could argue that every family should have one of those stuck in their first aid kit or whatever when they go to travel.
Well, so bringing it back to pharmacogenomics and or genetic pharmaceutical profiling, I am curious, before we get into just the examples and case studies, is there a reason why is there skepticism of why doctors haven't adopted pharmacogenomics into their practice? Or like, what has been sort of the main drivers that's been slowing down this adoption? Because I mean, it sounds incredible to be able to streamline somebody's medications.
Why don't you take a stab at that now?
Unfortunately, I think it's the medical training hasn't caught up with what's out there. And give an example, I was traveling back from a medical conference on a flight here into Columbia, and I was seated next to one of the chief residents of the PM&R program. And so I asked
Physical medicine and rehab.
Physical medicine rehabilitation. And I said, are you guys using specifically genetic pharmaceutical profiling to determine when you're treating pain, who should be on what pain medicines? Because I think that that's very important. If you've suffered a massive trauma, let's say you fell out of a deer stand, you broke every bone in your body and you're in pain, it's important to know what's going to work for pain with the least number of side effects, and so you won't get sedated or have respiratory problems or things like that. And it's real important sometimes with the spinal cord injured patients and things like that. And he said, no, I don't know what that is. And I said, you haven't had a lecture on this? And he said, no, I haven't. And so I explained to him what it was. This was within the last 4 years. I said, I've been doing this for some time now, and I feel like that it's critical in those situations where people are going to have to be on pain medication for a long period of time. Because if you have a patient and you put them on hydrocodone and they can't metabolize it into the active metabolite, you'll never get any pain relief. You may get sedation, or you may get problems with constipation or something like that, but you'll never get pain relief. And, it's just vitally important that our education system catch up with what the technology is.
Right.
But every time that our government doesn't pay for a test, the industry as a whole
Right.
doesn't cover the test, and therefore we don't lecture about the test because we don't want our medical students to go out and order a test that's not going to be paid for in our system because somebody has to eat the cost.
So again, that's an example of how the current healthcare delivery paradigm fails us when everything is set up around insurance reimbursement and reacting to something that's already happened. So with, we got this pharmacogenetic profiling suburb. I love that, by the way. You would have to do that a priori and have that data sitting there ready to utilize in your prescribing patterns. And as you say, it's not as if there's a conspiracy to keep it out of whatever, but if reimbursement is how healthcare, how the algorithm, so to speak, for healthcare delivery is set up around reimbursement, and there's no reimbursement, then there's no healthcare delivery.
All right.
Even when that's a great idea.
Well, not that I'm a conspiracy theorist in any way. I'll say from afar. But the initial thought though is that pharmaceutical companies would be pretty upset with just this progressing, and just because I feel like it's going to affect their industry the most, right? And so this is
it can affect you in two different ways. There are some drugs that may not be utilized as often, especially, and I could launch into an example of that if you want me to, but there are going to be other drugs that are promoted that are essential that people get on, otherwise they potentially could die from complications. And so, I think as doctors, we have to expand our view, okay? If I were a pharmaceutical industry, I would go to every medical school and I would say, I'm going to give you my drug free so that you're going to teach the medical student about my drug and where to use it appropriately, okay? And then whenever they get out into practice, those first 5 years, medical students are practicing habits. They have been limited on their formulary. They don't know exactly what works the best because that training institution may not have taught them that this drug is better than the one that was on their profile that they got to choose from. And so they are going about their business just prescribing the same medications over and over and over. And then all of a sudden they realize, hey, this patient did a lot better on this medication. I'm going to start using that medication. And they gradually branch out into what they feel comfortable with. And if they have bad experiences with a drug, they may not ever use it again. But gradually, as your practice goes on and you learn more about the medications that are available, the broader your spectrum is in your prescribing habits.
Yeah.
One time, one of the insurance companies sent me a profile on my use of antidepressants. And what I was surprised about was that almost every antidepressant I used, but all of them were 5 to 10% of the group.
Yeah.
And it's because that over time, as you prescribe those medications, you're using the side effects of the medications as part of your treatment program to help the patient, like rest better or have less anxiety or whatever. And so it's not just the depression you're managing, but you're also managing the other aspects of their condition. And so, you may use Zoloft at night because it's a little bit more sedating than Celexa that you're going to dose in the morning.
More active.
And, things like that. And so you start thinking about these other ways, but then you look at the genetic pharmaceutical profiling and said, okay, I'll just launch into an example. And a patient that by the psychiatrist had been increased to 3 times the normal amount of medication. Okay. When I got back their profile, it said that they were a metabolizer of the drug such that they needed 1/4 of the lowest dose. Okay.
So they had 32 times.
They had 32 times the amount that they needed. They had not normalized on their depression rating scale. And I immediately took that patient and, contrary to all guidelines, I took them from the highest dose down to a 1/4 dose. The next time I saw that patient, they had normalized on their depression rating scale. Totally normal. And that's what we've been taught to do, is that when a low dose of antidepressant doesn't work, the next time you run that depression rating scale and it's not normal, they say go up on the dose. And you do that 3 times, basically, and you find that they don't respond. So you switch to a different agent, and then you go through the same process again. That's the standard of what we've been taught, but it's not what we should be doing for that patient. It's not
what the science
financially, it's not the right thing to do. For the patient, it's not the right thing to do. You want to know what antidepressant is going to work in that patient from day one.
And looking at the metabolic pathways is leveraging the science of today to practice better medicine.
It almost seems like it was just so experimental. Where you're just trying to figure out as you go, did this work? No, it doesn't work. Okay, well, maybe this will work. And then you just continue to increase it.
And that was part of what you're saying. Nitrate out 3 times, so you switch to another one. You saturate it up and switch to another one.
Think about the amount of money that you're spending each time that you have to switch medications. You're not talking about medications that just cost $20 or whatever. A lot of these medications that we're talking about, they're going to cost $200. You got a depressed person that's potentially got financial problems already, and you're taking them through these titrations that are causing them to have multiple scripts that they have to get filled, and you're just driving up the cost the whole time. At the same time, you're risking them committing suicide.
I think the state of Hawaii, I don't know who makes Pfizer, so that's good. I don't have to. Or I say Pfizer. I'm sorry. I don't know who makes Plavix, clopidogrel. But the state of Hawaii sued the maker for $586 million or something and won. And the reason is that whoever that manufacturer is knowingly, check me on the $586 million, knowingly prescribed it, knowing that up to 1/4 of people would get zero benefit of it because it's a prodrug. So if you don't metabolize the drug to its active form, you get zero benefit, all the downside and zero benefit. So the state of Hawaii says, all right, Hawaiians have some very large percentage of the population not able to do that metabolic step to its active form. And whoever the drug manufacturer is knew the whole time that that was the case, and that there was a simple pharmacogenetic profiling that could have been done to determine who would benefit. And that's why the award was so large.
But when you start talking about the amount of money, I did some quick calculations, and I'll tell another story, but there's a drug called Metoprolol that's a beta blocker. It's used for hypertension, heart arrhythmias, angina, myocardial infarction. After MI, a lot of times that'll be the first drug that doctors will reach for because it lowers the metabolic demand of the tissue as far as how much oxygen it requires, so it kind of protects the heart a bit. And it's a beta blocker after an MI is just standard of care. Well, unfortunately, 8%, that's 8 out of 100 people, cannot metabolize the metoprolol appropriately. And so what happens with those people is they go into heart failure. Okay?
They're metabolizing it too quickly or too slowly?
Well, it's metabolized extensively by the hepatic CYP2D6 enzyme, and 8% of Caucasians and 2% of other populations have absent CYP2D6 activity.
So
And so they never metabolize it.
they never metabolize it to the active form, or it accumulates in the blood.
I am uncertain on that.
Okay.
I would have to go back and relook at that. But what happens is that they go into heart failure, they can potentially die. So I had a total of 3 patients initially that were recurrently going to the hospital. Every month, they would end up in the hospital. And at that time, I believe the cost was around $20,000 that they were averaging that they would have to be in the hospital per patient each time they went into heart failure. And the cost right now, I looked it up earlier today, is $31,141.50 on the average for one hospitalization for congestive heart failure. Okay. And I had 3 patients that were going in almost monthly for that. But if you just calculate out of 1,000 people, okay, you would have 80 potentially that you need to make sure that they're able to metabolize metoprolol appropriately. But if you had one episode of heart failure in those 80 people and they went to the hospital, that would be a cost of $2.4 million just for 80 people. Okay. Now this cost, the cost of this test that we're talking about to find out if the patient needs to be on a different medication, there's 2 other choices that you can make. You can go to Coreg or Biostolic, either one of those 2. But if you want to find out if your patient is one of those patients, it costs you $275. Okay. We're talking about for testing all 1,000 people, that's $27,000, $20,750. You're talking about a savings of over 10 times the amount by just keeping them out of the hospital for one hospitalization for congestive heart failure. And unfortunately, there are cardiologists that don't know about metoprolol and not being able to metabolize it appropriately and keeping people out of heart failure. And the first 3 patients that I pulled the drug on, the cardiologist came to me and said, "Hey, what are you doing? Switching these people over." And I said, "Well, I did the genetic test. I know that their cause of heart failure is potentially this. Let's see what happens."
Yeah.
And, after that, they began to listen to me about what it was that I was trying to do. But this will blow your mind. 15,542,999 people are on metoprolol in the United States today.
That begs the question of how many of them we don't know that are going to be adversely affected by that.
8%. Well, 8% is 1,243,439. And if you take that times one hospitalization, you're at $3.8 trillion. Now, that can't be the full number because we know that the budget for healthcare as far as the United States is 7.7 trillion, but it's a substantial amount of money that we ought to be looking at in order to save it for ourselves and for other generations. I mean,
What do you think?
and we're talking about healthcare costs here going up astronomically. Why are we not looking at something that's going to save that amount of money?
So you've thought about this a lot. What do you think the reasons are?
I think that we're just failing all the way around. You know, we are willing, I just saw this last week, the Medical Journal Watch was talking about how much money we're willing to spend on weight reduction by Wegovy and Ozempic and things like that. We're talking about doubling the Medicare budget, which is $3.9 trillion. We're talking about doubling that over the next few years to help people lose weight. Okay. Now, we've got our priorities messed up. If we can't deliver quality health care at a lower cost, we've got our priorities messed up. And we have to, in some way, we got to start reeling this back in, or we spend more money right now on our healthcare budget than we do on protecting our nation as far as the military is concerned.
Those curves crossed about 30 years
That's
ago.
been forever. It's almost 4 times the amount right now, and they're predicting that it's going to be 7 to 8 times the amount by next year if we don't do something about this problem. Why we're so blinded with blinders on as far as, I mean, rolling some of this stuff out that can save money. I think we haven't had anyone that is speaking up to really push, you know, getting the savings out there, telling people how you can save money, especially when the price of this genetic testing is coming down. It has come down to the point where everybody ought to have it at least once in your life. Your genes are not going to change unless you get a bone marrow transplant of somebody else's bone marrow and you start all over. So you might as well get it done, know what drugs work for you, know what kind of pain management you can get from pain medicine, know what they should treat you with for heart failure, know what you need for depression. You know, all of these major things that we spend buku bucks on, we should know what we can be treated with that would be effective.
Now, something that's came across my mind is, let's say we have listeners that are listening to this and then they want to take it into their own hands. They get pharmacogenomics done and bring it to their doctor asking for, I guess, certain prescriptions for them. I can imagine, like, would that then approach be then?
Well, first of all, the FDA does not want patients going out and looking at their own pharmacogenomic data or pharmacogenetic profiling because they're afraid that patients will start changing their medications without consulting their doctor. But say that they do. The problem is doctors like to be very comfortable with the test that they order, understand the science behind it, the benefits and the limitations of the test. And just quite frankly, there's this knowledge gap that Dr. Scoles was getting at.
Now, we have to have a national education program for physicians first to say, you know, this is a valid test. It will save money. You know, I did the numbers on my practice. I think in the first 3 years, I saved $15 million on 650 people.
Just in your practice.
Just in my practice.
That's amazing.
I went to the legislature in Missouri and I said, everybody needs this test. And nobody would sponsor legislation. You know, the amount of money that could be saved in 1 year by doing this would pay for the program itself. And you have it for a lifetime because your genetics isn't going to change. And yeah, there will be new medications that come out, but hopefully, you know, most of the genetic companies are saying, we'll add on those medications. If you send in those medications to us, we'll add them on and run them back through to see if they have the appropriate genes to metabolize them. And in my own practice, what I've tried to emphasize with my patients is when you get this report back, it's going to be 18 to 28 pages long. It's got 3 columns on it: safe to use, needs modification in dosing, completely,
don't use it.
or don't use it all. And you take a photograph of that on your phone and you carry it around with you and you say, okay, when you're in the ER and a doctor's ready to prescribe medication, let me look it up on my list. Is this safe? Is it not safe? What do we need to do here? And so that is a gradual thing that I think if we're going to implement it, we need to do that. But AI can help us here too. If you have a genetic profile that tells you what medications are safe, I want AI checking my physician to make sure that he's prescribing the right thing for me. And so that has to be built into our medical record system so that every time that I'm prescribing, it goes through that system. The number one reason for lawsuits right now in physicians is prescribing something that they're already known to be allergic to and a complication of that.
So the Biography Health Platform has that capability. I think what's going to happen, and what I'm seeing happening, and even in places like Columbia, is patients are going to be demanding personalized precision medicine. You know, they're the ones that are going to come in and ask for it. And you see these precision medicine, wellness, longevity type practices springing up. And, you know, in my practice at the Beverly Hills Institute for Precision Medicine, patients are coming and they're asking if we do this kind of thing. They suspect that we do, and we do. And so I would tell people out there, look for those wellness practices like yours that brand themselves toward wellness and longevity and are willing to use the real evidence-based science of today. I don't mean that, you know, the hokey stuff that, you know, take one of these and you'll live longer, but you know, the serious medicine and pharmacogenetic profiling is definitely definitely ready for prime time. In fact, in California, our Medicaid will now pay for pharmacogenetic profiling. Medi-Cal.
And the insurances are gradually adopting this. I've seen more in the last year that have been paid for than have not, which we're starting to see that trend. I think that they see the long-term benefit for it. The problem with the insurance companies in general, though, is that they look at the patients that they have today, knowing that they're going to change to another insurance in 2 years and or less, and they want to pay for today.
Right.
And they gear everything to today and not thinking long-term on what's going to be saved down the road. And so when you're taking that short-term view, because you have so many people that go for the cheaper plan every year, then what happens is you're you're never really paying for what's going to happen tomorrow. And this is one of those things, it's going to happen tomorrow, and it's certain to happen tomorrow, but are we going to pay for it today and let them carry that benefit into their next plan? And patients really need to be their own advocates and say, hey, look, I want this because it's going to affect me the rest of my life. And, one of the other examples that I have is had a patient that had 13 years of ulcers, and she had never been able to get rid of her ulcers. She was on double dose pump blockers twice a day, and we can
Pain every day.
pain every day. And when I got her genetic pharmaceutical profiling back, it said she was a rapid metabolizer of pump blockers, and she needed to be on 4 times the dose.
So she was, her
Ingredients.
enzymes were chewing the
We were chewing it up,
could mount
and it would never
therapeutic serum levels.
stop the acid. But when we changed her dose then to what the testing said, she called me in
What'd you
3
change it
days.
to?
She called me in 3 days. I believe it was like Protonics and the Orty.
Like
Fever tablets twice a day.
4
Yeah.
times the normal dose.
Yeah, and in 3 days, she called me back. She said, I'm pain-free for the first time in 13 years. I sat at my desk and cried because I knew the suffering that lady had been through. And the next time we scoped her, she was ulcer-free.
It's a
I mean,
story.
You can't say how much it altered her life just being pain-free. And it was because she had the ulcers, and there was an answer, but we just hadn't ever figured it out.
It sounds like these heart failure patients, similar huge benefit.
Oh,
They don't want to be spending their
the
time in the hospital.
those 3 patients, I think to today, they haven't been back in for heart failure.
They were frequent flyer.
They were in every month. And, you've been around long enough in medicine that there are clinics that the only thing that they do is infuse people with medications to get them back out of heart failure. And my personal question is, has anyone ever walked into one of those clinics and done genetic pharmaceutical profiling on any of the patients in that
Like
clinic?
you say, since Metoprolol was such a mainstay, and yet it's such a
How many people
high failure rate.
would you not have to treat with, an infusion to get them out of heart failure?
Yeah.
I don't know the answer, but I think it'd at least be 8%.
Well, really, your thesis, if you broaden it just from pharmacogenetic profiling, is we could be a hell of a lot smarter about how we go about this, given that you can project these things a priori, so beforehand, so to speak. So you might as well, have that knowledge. Forewarned is forearmed, and you can head these things off. That's just leveraging the science of today.
It's incredible, but unfortunately, it's going to have to start with a massive education component.
Of physicians. I think the other thing that's pushing it is patients demanding it because they're getting wind of it, through programs like this and, stories from their friends, et cetera. I did this genetic test. They gave me all these insights and it's changed my life. And, I'm seeing it not just in pharmacogenetic profiling, but, across the board and predicting the risk of chronic disease and save lives. And I appreciate your emotional reaction of retelling that story. It's, that you say someone from a heart attack, or you've
Just
predicted that they have markedly increased risk of some kind of cancer, and you do higher levels of vigilance and screening, and you know they're not going to die of that thing, that had you not done this screening to gain, insights into where their risks are, just like with the Metoprolol, it's an amazing time we live in.
So with education, informing physicians about this field and the fast pace of this field, then are there any resources that you two can share in case physicians want to do their own homework in learning about this? Is there articles or their blogs, newspapers, well, not in that newspapers, newsletters, videos that you really like to go to look for more information?
So for me, I like the Inside Precision Medicine. There's also Gen Engineering. So I guess it started out as a genetic engineering publication. I mean, these are all newsletters online that they can subscribe to. There's just a whole bunch of them. You can do the usual Google search, but those are pretty legit. There's also some of the companies springing up, in this space, do a fair amount of education on this new science. Well, I say it's like it's new science on this science, period.
One of the things that I did in preparation for coming here today was just to look at guidelines to see who had incorporated genetic pharmaceutical profiling into their guidelines. And to my surprise, hemoncology was the first to do that.
Yeah.
And specifically for the pain issue. And so I believe it was in 2022, they recommended for the first time that you get the testing for pain management with genetic pharmaceutical profiling. And so I would encourage people to push for guidelines in their own areas.
You're speaking to physicians.
Yeah, to physicians and the patients to be an advocate for that. Any problems that they run into along the way, be an advocate for yourself and try to get the information. And, I want to just reemphasize precision medicine is an approach that offers a great potential to prescribe the right medication at the right dose to the right patient at the right time. And we need to really advocate for that in each and every patient. And we really need to stick to those standards as far as trying to treat people appropriately.
Yeah, I like that.
I love it. And Dr. Scoles, if let's say there's physicians that are listening to this or other patients that are listening to this that want to reach out and get more information from you, what's the best way that they can reach out to you?
Well, my email address is drscoles@socket.net. My personal phone number is 573-424-6494. And the practice that I'm in, I have people call me all the time. So another phone call is not going to harm me.
And for me, Dr. Stanford, STANFORD at BHIPM.com. Beverly Hills Institute for Precision Medicine.com.
Got it. Well, thank you two for hopping on to the podcast. And I mean, this is pretty mind blowing, especially just from some of the examples and statistics that you shared. And I mean, I know I say this every time we have guests, but I'm just so grateful to be able to sit here with two renowned experts in just this growing field and just new revolution of medicine. So thank you for sharing.
It's fun to work in that field. Yeah, it's fun to be at the cutting edge.
Bringing up fire, I was like, oh.
We can be sure that all patients in the future are going to have genetic pharmaceutical profiling, and we can be sure that there's going to be genetic testing that occurs with data analytics to predict your future risk of chronic diseases. That is the way of the future. The future is here now. It's just not evenly distributed. So if you happen to be lucky enough to get Dr. Scoles, you're going to get some precision medicine. If you're in our practice, you're going to get precision medicine.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.